Thank you, and thank all of you for being here. And, you know, May is Women's Health Month. Apropos, it's Mother's Day, so, you know, we take care of everybody else, so in May, they look after us. But I really appreciate everybody coming, and hopefully I will impart some information that will help you guys, and you can have some pearls to take home as far as what your health means versus screening population-based health. And that's sort of the topic that I wanted to speak about because, you know, with all of the different organizations coming out with screening recommendations, sometimes it's very confusing. It's confusing for the doctors, and I know that it's confusing for you guys as patients. So hopefully we'll go over some stuff tonight that will clear that up a little bit. And if it muddies the water, I'll try to answer questions when we finish. So the objectives tonight is to learn about evidence-based guidelines. And guidelines are meant to offer advice for patients and physicians for treatment and discuss current guidelines in women's health. We also want to know what areas patients do not meet the population-based guidelines because all of the guidelines are based on population health, and it is based on a healthy population. So if you fall out of that healthy population or if you have certain risk factors, then your treatment is going to be different. We want to discuss the ways to ensure that you're being screened appropriately for each individual health need and risk, and we're going to discuss other concerns that you may have. So we're going to start with what is evidence-based medicine and how are guidelines developed. The Institute of Medicine states that evidence-based guidelines are systematically developed statements to assist practitioner and patient decisions about appropriate health care for specific clinical situations or circumstances. So basically, the reason we have them is to prescribe appropriate care based on science, because, you know, we want the literature and the medical science to back up what treatments that we are prescribing for our patients, and I'm sure they want that too. It's to decrease practice variation. You know, if you're being treated in Thomasville, Georgia, you should have the same option of treatments that they have in Baltimore, Maryland, or Massachusetts. So, you know, with today's technology, it should not be difficult for your physicians in Thomasville to access the same information and offer you options which are comparable to the options all over the country. And actually all over the world. We are now getting into a more global health system and learning a lot more from some of the countries over in Europe as well. It's to focus, it offers a focus on education to physicians as well. You know, when your specialty society comes down with guidelines, that's their recommendation, and it offers an opportunity to educate physicians and providers. It's also used to promote efficiency with resources. You know, our resources are not open-ended, and if the screening or recommendations we're offering are outdated or not working, or we've done such a good job at it, we don't need to do it as frequently anymore, then we need to look at that and change our guidelines so that it's more appropriate and we can help to preserve those resources and use them somewhere else. And it's used to encourage future research, because sometimes when we're looking at these guidelines and we look at the research, we recognize there are areas that we don't have enough knowledge to be able to make a recommendation on what we should do. And so that's an opportunity for the scientists and the researchers to use to go back to their labs or clinical science and do more research and come up with evidence-based recommendations for whatever the issue is. And actually, when I go through this presentation, there's going to be a few areas where I'm going to point out that there's not enough science to make a recommendation. So who develops these guidelines? Well, there is a government entity that is politically appointed. It's the USPS Task Force, which stands for, I'm going to try to get this right. I'm blanking. I'll come back to that one. And specialty societies like ACOG, which is the American Congress of OBGYNs, the American College of Radiology, the American College of Physicians, which are your internal medicine doctors, the American Academy of Family Physicians, and then there are other groups that also come out with guidelines, which are your non-for-profit consumer organizations like the American Cancer Society, the American Heart Association, and the American Diabetic Association. And so there's some question, and the question has been asked, why don't we screen everything for everybody? Well, there are risks to screening. And if you overscreen patients, you have the potential to cause harm. So you need to come to the middle ground where your screening is at a point where it actually helps the patients instead of potentially harms the patients. And I'll talk about pap smears in a few minutes, but we used to screen young women. And we don't screen young women anymore until they're 21 years old because we were overtreating for precancer changes that their body would cure on its own. And that would cause them more difficulty later in life with carrying pregnancies and other issues. So there are reasons that you don't screen for everything for everybody, and as the science gets better, all of these guidelines will be refined and other recommendations will come out. So we're going to start with breast cancer screening. There's 249,260 new cases of breast cancer each year, or for 2016, that's the projected rate. 40,890 deaths due to breast cancer. And we all know mammography is the best option we have for screening. And so let's look at some of the screening guidelines by the different organizations, because breast cancer is actually mammography and screening of breast cancer is probably the most controversial between different organizations. The United States Preventive Services Task Force, I got it, actually came out with a guideline a few years ago, and they did not want anybody to be screened under the age of 40, and there was such an uproar in this country that Congress passed a law that you can't do that. Don't care what the science says, can't do it. So they came back with the recommendation that women of the age 40 to 49 should have the opportunity to be screened, and it's an individual decision. Between 50 and 74 years of age, they recommend every 2 years. And over 75, this is one of those not enough evidence out there to make a recommendation. Over 75 years of age, there's no recommendation. So most of your physicians, especially if you've got at least 10 years of longevity, are going to continue to offer mammography for you. The American Cancer Society, their guidelines state that between 40 and 44 years of age, the patient should have the opportunity. Again, one of those vague, if you want it, then you should get it. It should be paid for. Discussion between you and your doctor and your provider. And this is for average risked patients. This is not for patients at high risk. And I apologize, I've had a cold and my voice may give out, but we'll try to get through it. Women 45 to 54 should have annual screening, and women over the age of 55 with average risk should be offered every other year, but have the opportunity to have it every year if they choose. And they are silent on women over the age of 74, you know. ACOG and the American College of Radiology, it's simple, and it should be offered annually over the age of 40. So who are the women at risk for breast cancer and do not fall into the general population health-based screening. If you have a first-degree relative who has had cancer, which is a mother, sister, or even in some cases a father, you don't fall into this screening recommendation. You need it every year. If you are known or have a known history of a BRCA positive or a family member has BRCA positive gene, these are the genetic breast cancers, you need a mammogram every year. If you have dense breasts, there are different recommendations for you, and some people would recommend an MRI annually, but most everybody would recommend at least a mammogram every year. And if you've had a history of breast cancer in your other breast, you're at high risk and you need a mammogram every year. So the bottom line is to discuss these risks, discuss your risks with your health care provider, and you and your provider come up with the plan that's right for you. And you're going to hear that theme through this entire talk. So I don't know how many of you remember this, but I think I was about 11 when the American Cancer Society started this very popular "It's Your Birthday, Get Your Pap Smear" ad campaign. And I lived in Douglas, Georgia at the time, so if I heard it, everybody had to hear it. So it was a very successful ad campaign, and you know, cervical cancer was one of those diseases that we didn't understand at the time and was rampant, and a lot of women were dying of cervical cancer because it was advanced before we were able to diagnose it. So they really did a good job, and women learned they needed, it's their birthday, go get your pap smear every year. And that was the traditional, when in the 1950s, Dr. Papanikolai developed a pap smear, the traditional pap smear, and there were limitations to that pap smear. So today we have a liquid-based pap smear, which is much more specific and is better at screening. So our science has changed over the last 20 years because we've had a new method of looking at the cervix with the liquid-based pap smear versus that older Papanikolai smear. So if you're under the age of 21, the recommendation is no pap smear. If you're sexually active, you do need to come in and you need to be checked for STDs. So you need a chlamydia and gonorrhea, and it's anybody who is sexually active. If you're under 21 and you have become sexually active, you need to come in every year and get that test. And the reason is because those infections can cause infertility. And the quicker they are treated, the better your chance of cure is. So if anybody has children in this age, take it home. If you're age 21 to 29, the recommendation is a pap smear every 3 years and annual chlamydia and gonorrhea screens. So if you're over the age of 30, there's two options. One is a pap smear, and this is for general public population. If you're at high risk, this doesn't count for you. Every 3 years for a pap smear, or if you do co-testing with the human papillomavirus and the pap smear, you don't have to have a pap smear for 5 years. You do that testing every 5 years. You still need your breast exam, still need your pelvic exam, and over the age of 35 still need a rectal exam. So this does not take away your annual visit. It just means that if you're not at high risk, we can skip the pap smear. So what happens over the age of 65? The recommendation, if you're at low risk, is that you can stop having a pap smear over the age of 65, or if you're 65, 15 years from the last time you had an abnormal pap smear. So if you had an abnormal pap smear and was treated at 60, then you've got to go to 75 for pap smears. So you need 15 years from the last time you had an abnormal pap smear. Post-hysterectomy patients, there's a lot of debate out there about this, and for low-risk patients who have not had the hysterectomy for a malignancy or pre-malignant issue, you do not have to have Pap smears. And this is Dr. Reed speaking. I will tell you, it's very difficult for me to follow that guideline, because I have seen low-risk patients who've never had an abnormal Pap smear have dysplasia of the vagina. So and this is off script from what this recommendation is, I generally will still do a Pap smear on a hysterectomy patient every 3 to 5 years. I just think it's good medicine. You're my patient, you're sitting in front of me, and it's the art of medicine. So, and also with the HPV vaccinations now, females who've had the vaccination should still get their Pap smears. And they should not think just because they got the vaccination that they are or not vulnerable to it. The vaccinations only cover for 2 of the 18 viruses that are high risk. Having said that, those 2 viruses cause 70% of the cervical cancers in the world, not just in the United States population. So, but there's still the others out there that can cause it. So even though your child or grandchild or whoever may have gotten the vaccination series, they still need to be diligent about coming in and getting their Pap smears. So who is at high risk for cervical cancer and does not fall under this genre of guidelines? If you have had a Pap smear, abnormal Pap smear with a high-risk HPV Pap, you need an annual Pap smear. If you have a history of high-grade lesions like dysplasia, CIN2, 3, or carcinoma in situ, you need an annual Pap smear. If you've had a hysterectomy for a malignant or a pre-malignant lesion, you need a Pap smear every year. So now let's switch to ovarian cancer. Ovarian cancer, in 2016, the estimate cases are going to be about 22,280, and the deaths are going to be 14,240. And so you can look and see the statistics there that a little over 50% of women who get ovarian cancer are not going to make it. Well, when I was in training, it was 80%. So our medicine has gotten better, but there's no standard recommendation for annual screening for ovarian cancer. So there's no population-based recommendation other than an annual pelvic exam, which is why even though you don't need a Pap smear every year, if you've got ovaries, you still need an annual pelvic exam. That's the only screening test for ovarian cancer. So who does not fall under that umbrella? It is the patients who have the genetic marker for BRCA2 and BRCA1. So if you're positive for that or it runs in your family, you need a little bit more of a detailed screening. Or if a first-degree relative has had ovarian cancer, you need a more detailed screening, and we would screen you more carefully. Other than just a pelvic exam, you would be offered an annual blood test, the CA-125, and you would be offered an ultrasound every 2 years to look at your ovaries. But that's not a general population recommendation, that's an at-risk population recommendation. So what about lung cancer screening? We have some gentlemen in the room, so I've included both sexes as far as new cases this year, estimated 224,390. And thank y'all for coming, by the way. It's nice to see y'all here. Women only, 106,470 cases, new cases of lung cancer estimated for 2016. Deaths, 158,000, and that includes both sexes. But for women, out of the 106,000, 72,160. So the statistics on that one is even worse than the ovarian cancer statistic. So screening recommendations, and this is pretty new, and this comes from the task force, the Preventive Services Task Force. If you've had a 30-year history of smoking and haven't quit within the last 15 years, and you're turning 50, you need a low-dose CT scan every year until you're 15 years out from stopping smoking. So that's something, if you're a smoker, that you need to talk to your physician about, because, and I did a little bit of a computer search, if you add up all of the deaths, and these are the deaths, and this is my only note that I brought, but if you add up all the deaths from breast cancer, cervical cancer, ovarian cancer, and uterine cancer, you come up with 69,720. And that's what all of us women are worried about: breast, ovarian, cervical, and uterine. Having said that, 72,160 women are going to die of lung cancer. Totally, 90% preventable. So, if you stop smoking before you turn 40, you decrease your chance by 90% of having a cancer death. And your life expectancy is 10 years less if you're a smoker. And smokeless tobacco also causes cancer, so don't think it's better just because you're doing that. And I will also tell you, these e-cigarettes are still being evaluated. Nobody knows yet, because you're inhaling that stuff into your lungs, and we don't know yet whether it's any better than cigarettes. So now we're going to talk about skin cancer prevention. So I want y'all to remember this little phrase: slip, slap, slop, and wrap. Slip on a shirt, slap on a wide brim hat, slop on sunscreen, and wrap your eyes with UV protection sunglasses. So when should you get a routine skin exam? Well, guess what? We don't recommend routine skin exams, and that's not a general population recommendation. Having said that, there are 76,380 new cases of lymphoma each year. So who should? Okay, I'm getting ahead of myself. So if you have used tanning beds before age 35, and you guys can take this back to y'all's kids and grandkids, you've increased your risk of melanoma by 59%. And the risk increases with each use. Women younger than 30 are 6 times more likely to develop melanoma if they tan indoors. So the appropriate time to go into the sun, but remember that slip, slap, slop, and wrap, is before 10 o'clock in the morning and after 4 o'clock in the afternoon. So now we'll go to the colon cancer screening, everybody's favorite topic, especially at dinner. These recommendations come from the American Cancer Society, and they're pretty simple. If you're over the age of 50, and this is population-based recommendations, you get a colonoscopy every 10 years, or you fill out those little cards and send them back to us every year. Or if you do the DNA test or the immunotherapy test, then you can do that every 3 years. Or you do a CT colonoscopy every 5 years. Now, these are the recommendations of the American Cancer Society. The CT colonoscopy was not recommended by the task force, and it is not covered under Medicare. So payment policy issues could be issues on some of these tests. And some of your insurance company will not pay for the FIT and the DNA test every 3 years. They want you to do the annual FOBT, or they want you to do the colonoscopy. So some of this you need to check with your insurance company, talk to your provider, but colon cancer is almost 100% preventable with screening. And my father died of colon cancer at age 55. So that's an important issue for me. So we're talking about women's health, and it is the year of the woman. So let's talk about cardiovascular disease. How do you screen for it, and what do the guidelines say? Cardiovascular disease is the #1 killer in women, above lung cancer, above everything else. The only way for you to diagnose a cardiovascular problem is an annual physical exam where we check your blood pressure, we check your weight, we check your labs, we screen your cholesterol, we screen your triglycerides, and we screen for diabetes. We also screen for smoking. So your annual physical exam is the recommended screening for cardiovascular disease. Most of the time, it's by the time you get into the office and you get checked for this, it's too late and you've already got some of this stuff going on. And some patients are going to be trapped by their genetics. I mean, some patients are going to have genetically high cholesterol and triglycerides, and you're going to need to work with your doctor or your provider and figure out what is best for you. You may need a statin, you may need a strict diet. But the way you prevent it is diet, and y'all are going to hear this all through this talk. Diet, exercise, stop smoking, and talk to your doctor about whether medication is appropriate for you. A 10-pound weight loss will decrease your blood pressure to the point that you may be able to get off your blood pressure medicine with exercise. So talk to your doctor. If you're overweight, try to get the weight under control. If you're not exercising, even 30 minutes of walking a day or 4 times a week is enough to help. But the #1 killer is cardiovascular disease. So now we're going to talk a little bit about bone health and osteoporosis. Who needs a bone density and when? How can you prevent bone loss? And who is at risk for bone loss? If you have a positive family member with osteoporosis, mother, father, or both, then you're at risk. And you don't necessarily fall under that age 65, get a bone density. If you've had a previous atraumatic fracture of the spine or hip, you are at risk. If you've had menstrual irregularities like premature menopause, history of infrequent periods, exercise-induced lack of periods like anorexia or bulimia, those can cause a risk for bone loss. And if you're very, very, very thin and have a low body mass index, then you're at risk for bone loss. There are primary and secondary risks as well. And for primary risks, some medical illnesses can cause it. Premature ovarian failure, we've already discussed. Hyperprolactinemia is when the pituitary produces too much prolactin. Malabsorption syndromes like Crohn's disease or celiac, and a lot of people are being diagnosed these days with celiac. Hyperparathyroid or hyperthyroid, and that's when your thyroid's producing too much hormone. Bone marrow disorders, rheumatoid arthritis, and certain medications put you at risk for increased bone loss, including steroids and heparin or other blood thinners, and anticonvulsant medications for people who have seizures. Secondary risks are nutritional deficiency, not enough calcium and vitamin D, or prolonged immobility, for instance, patients with spinal cord injuries, and they are extended bed rest or have minimal exercise. Excessive alcohol can cause bone loss, and cigarette smoking can cause bone loss. So the recommendations are for women at routine risk to have their bone density test at age 65 or older. If you break a bone after the age of 50, and this is an atraumatic break, then you should start having them. Women of menopausal age with risk factors such as smoking should have these, or medications, some of those medications we talked about. And postmenopausal women under the age of 65 who have risk factors should start their screening. So basically all these things, talk to your doctor, determine what your risks are, and then follow the recommendation that you two decide together. How do you prevent it? If you're a smoker, you stop smoking. If you're drinking alcohol too much, you stop drinking too much alcohol. You eat a calcium-rich diet with calcium and vitamin D supplements. And postmenopausal patients need 1,500 milligrams of calcium a day. And if you're not getting enough in your diet, then you need to supplement. And yes, calcium is constipating, so try to find one with magnesium and D in it. That's just another one of those, dinner time conversations you don't want to have. And then weight-bearing exercise. So here's another one of those: exercise, stop smoking, and eat a healthy diet. So in conclusion, talk to your health care provider about screening and treatment options that are best for you based on your individual health. If you're at average risk, these recommendations are totally appropriate for you. But if you have something that takes you outside of normal, then you need to have a different level of screening for all of these different illnesses. And I know we talked a lot about cancer, but that's generally what everybody is really worried about, and that's a lot of what our screening goes into. But just remember, the number one killer is cardiovascular disease. Any questions?
I was told by my doctor years ago that I needed to start taking calcium, for your bones back. So I started taking it, and it was making me constipated. But then I happened to be in a doctor's office, and I was reading this magazine, and it was saying that in order for the calcium to work right, you got to take the D. So I buy it at Walmart, the Equate, and it's calcium plus D.
And if you get the one that has the magnesium in it, it'll help with constipation.
Well, I don't have the calcium because that was
Okay.
unusual for me anyway. But when I started taking that calcium,
Yeah.
I didn't like
Yeah.
it. But after I started buying the calcium plus D,
That was better.
That D makes that calcium
Absorb right.
Yes, ma'am.
Do younger people need to take extra vitamin C and D as well?
If you're getting a balanced diet, the answer is you need to take about 600 milligrams of calcium. If you're not getting a balanced diet, the recommendation is about 1,000 milligrams. You do get a lot of calcium in your diet if you're doing milk products or meats, those type things. But it's more important after menopause than it is before menopause, unless you've got a family history of osteoporosis. And the other thing is, if you have taken or did take birth control pills during your younger years, that was protective of your bones during that period of time as well. And it's a known fact that women who did take birth control pills started into menopause with stronger bones than women who did not. Another benefit of the pill.
I was not sure exactly what you said about, I had a hysterectomy because of excessive bleeding when I was in my late 30s. and I still have my ovaries. Or do I have a risk
You don't need a pap smear, but you still need a pelvic exam.
of what?
An annual pelvic exam because you still have ovaries.
Yeah, okay.
You were next, and then we'll come back over here.
The colon guard that they've just come out with, what type of testing is that for the,
That, I think, is the DNA test.
okay. And then how often?
That one's every 3 years.
Okay.
And the question's the colon guard test is the DNA test, and that's an every 3-year test. The CT colonoscopy is out there, but a lot of insurers are not reimbursing for it because there's less expensive options.
I just wanted to ask, I see here that, it says something about the smoking. I'll be 69 for West Fair, my life is July 20th, but I just stopped smoking 3 years ago. And so,
When did you start smoking?
when I was 22, so.
How many packs a day did you smoke?
Almost a pack.
So a 30-year pack history would be 30 years of smoking a pack a day. So you're at risk and need to talk to your provider about that low dose
A long test.
CT scan.
Because, I mean, now I'm going like, gosh, I'm huffing and puffing. I know I put on 15 pounds, so I'm not smoking, so I'm eating. So the thing is, I'm going like, well, it's 15 pounds making me huff and puff like this, and I bend down to do my shoes, and I come back up and go like, so.
You qualify for the test. I mean, you fall under that blanket that's recommended to have it.
That BRCA gene, as far as the breast cancer, me and my sister are at high risk on our family. Is there an age that you can get tested to see if you're positive?
You can get tested at any age. Generally, what is good, let me go to the microphone so everybody can hear this. Her question was that she and her sister both are at high risk for cancer, and can you be screened at any age for the BRCA 1 and 2? You can be screened at any age for BRCA 1 and 2. Usually what genetic counselors like to do is to go to the sentinel case where the cancer started or as close to it as they can get, which means, and I don't know your family tree, but if your mother or your father got tested and they were negative, you two would not have to be tested. If it's grandmother who had it and an aunt, then your mother still needs to be the one to get tested. If it's maternal, your father needs to be the one to get tested if it's paternal. So they try to test the closest to where the cancer is as possible. And BRCA cancers are primarily breast and ovarian with some uterine. So when you look at the family tree, and some prostate. So when you look at the family tree and the genetic counselors talk to you about it, or your physician talks to you about it, and somebody had lung cancer, and somebody had ovarian cancer, and somebody had pancreatic cancer, and somebody had rectal cancer, and somebody had cervical cancer, those don't go together as the pattern that we usually see for the BRCA test. Having said that, there's other cancer syndromes out there like Lynch that some of those may go with. So that's one of the reasons I think as we get a little more sophisticated, we try to get you into someone who can counsel you based on your family tree and really try to figure out what cancers we're dealing with. And I predict that we don't know everything about the genetic cancers yet. And as we go forward in the future, especially as we learn more about the genetics, we're going to learn more of those types of clusters that go together, and we'll be able to test for them. But that's not really, a lot of those are not available yet.
Do you know what percentage of women that are diagnosed with breast cancer are under that 40 age?
It's a lot less than what you think. The average is in their 50s and 60s. Having said that, women who are diagnosed with breast cancer in their 40s have a much more aggressive cancer. It's the premenopausal patient, and so finding that cancer earlier is better. Doesn't always mean the outcome is different, but finding that cancer earlier is better for the patient.
But do you have any idea, like with the 20s and 30s, how many?
In their 20s and 30s?
Yeah, that you find.
You do find an occasional breast cancer in the 20s. In the 30s, maybe a few more, but it's really very, very small numbers that we're talking. And unfortunately, those cancers, when you're in your 20s and 30s, are very aggressive.
I was on the pill for quite a while, and I wasn't doing anything for me. So for the last 2 years, I've had 3 class treatments, and there was an improvement in my spine and a significant improvement in my hips. I just found out, if I understood it, you can only have 3 class so many times. Period.
Reclast is still one of the dendrolates, and that class of drug, the half-life is very long, and so it's not that you can't have it, it's just that the benefit is not there to continue to take it. So if you've been on the oral dendrolates for 10 years, you've taken all the goodie you're going to get. So that's probably the reason they're saying you can't take it more than that number of years. And I'd have to look up the reclass data to find out how many years that would be. But it's probably because the half-life of the drug is longer than you are going to have. I mean, some of these drugs, especially the dendrolates, stay in your system for 20, 30 years.
That's not necessarily a bad thing that you have to stop them.
No, it's not a bad thing. Because the drug is there, it's still working.
Continues to work in your body for years. I didn't know that.
It's in that dendrolate family. There's quite a few different drugs for bone health for treatment now. That's one of the families. There's another drug called Prolia, which works differently. So if these drugs were not working, if you were having major side effects from them, then there are other options for treatment.
Dr. Reed, someone in their 70s, with a sister who had ovarian cancer, how often should someone at that age to have a pap or be tested?
They should still be seen annually. How old was the sister?
It's in probably in her early 60s.
The risk is still there.
Cervical cancer to a sister should still do it every year?
Cervical cancer is a little bit different. Cervical cancer, we now know, is 95% caused by HPV. So cervical cancer is not one of those that we consider a genetic cancer. Unless you have one of the syndromes that cause adenocarcinomas instead of squamous cell, like the Lynch. You know, you could make an argument then that it might not have been HPV related because we have a family history of this. The other group that I meant to speak on when I was talking about colon cancer is the familial polyposis family. You know, there are families out there who have polyps that start showing up in their 20s, and then these family members are getting colon cancer when they're in their 30s. And if you have a family history of familial polyposis, and I mean, I'm talking about people who would have 20 or 30 polyps at a time when they have colonoscopy, then that's a little bit different, and your screening is very different.
What about breast, Dr. Reed, breast density? If, you know, the last couple of times I went back and forth to see my mammogram done, it's uncomfortable, first of all. Number two, you get a call back, but then you find out it's dealing with your breast density. Are y'all gonna come up with something a little different than what we're currently using to?
There are some things in the works to look at patients who have very dense breasts. One is 3D mammography. Could potentially offer help in that arena, but the current, most organizations currently would recommend going to MRI. The issue with that is getting your insurance company to pay for it, and they're very expensive. But, you know, 3D mammography is being researched as we speak. So in the next year or two, we probably are going to get stronger and stronger data and recommendations on use of 3D.
Do you think it will replace the regular mammography?
In my opinion, it probably will not, but it will be an adjunct to, and then when you screen, then you may be offered the upgrade to 3D so that they can be sure they're seeing what they think they are. And there are options for that now, and places where it's very helpful. So that's going to be one of those individual patient-based. Yeah. And at this point in time, most insurance companies are not paying for 3D, but I suspect that's going to change very soon.
Dr. Reed, I never had a broke bone until the age of 50, and it was a break in the fibula. Do I need a bone density?
Was it a traumatic break or
It
an,
almost went through the leg. It was
what,
like a titanium rod and screws. and
did you
places.
fall or something caused?
The fall.
Okay, that's not the same kind of break
Okay.
as the ones that would need the bone density. The breaks that occur without injury are the ones that we're talking about.
The earliest you need to be tested for a mammogram is at the age of 40 or 30.
40, unless you have a family history of a first-degree relative who had breast cancer. First-degree relative, sister, mother, and you know, fathers can get it too. Okay.
I've got a question, and it's concerning the ability to, I guess, perceive issues in women in the ER. Recently, my older sister, she's 54 this year. She experienced some chest pain one Saturday, and of course, it was outside of her doctor's hours. So she went to the local emergency room in Middle Georgia. The doctor that was working, you know, he checked her vitals and everything. He's like, well, nothing's happening now, so, you know, you can go home, and if it happens again, come back. So, of course, at that point, she's like, I'm not going back. She waits till Monday. They found out she had a blockage. So how do you, as far as women and our issues in the cardiovascular realm, what do you do to kind of prevent that from happening?
You know, blockage of your coronary arteries are very difficult to diagnose, especially in women. And chest pain is a indication, but it's also a very vague complaint. Because you can have chest pain with indigestion, you can have chest pain with a lot of other, and so depending on what her acuity was when the doctor saw her, would have keyed him as to which tests to have ordered. If all of her vital signs were fine and she wasn't having the chest pain again at that point in time, he may not have done the next level. I suspect most ERs probably would have at least ordered some cardiac enzymes in a patient who was having chest pain. But you can have chest pain even without your cardiac enzymes going up.
And he did order the enzyme because he was suspecting a heart attack, but of course the enzyme levels were wrong.
Right. And so as far as, standard of care and he did the appropriate tests. It's just that it doesn't always show up, and in the female population, sometimes it's more difficult.
Thank you all for coming.
Thank you all for coming. Y'all have been very attentive, and I think it's been a great group, so I've enjoyed it.